First of all, my name is Thomas Keeble. I'm a cardiologist at the Essex Cardiothoracic Centre, a large cardiac centre just east of London. And today we're going to talk about NIRS IVUS, unmasking vulnerable plaques, and how we can use that information to optimise our outcomes for our patients. I'm joined by a fantastic panel of hugely experienced NIRS IVUS users, as well as clinical academics. And I'm going to ask them to introduce themselves first, and then we'll crack on with the session. We've got 45 minutes. It's extremely short. We've got a lot to get through. We've made the presentations purposefully short to enable plenty of time for discussion, because we want you to really get to the heart of what this is all about. So please introduce yourselves along the panel, if that's okay.
Thanks, Tom. I'm John Davis. I also work at the Essex Cardiothoracic Centre, which is, as Tom said, just east of London. I'm a consultant cardiologist.
Yeah, I'm David Erling in Lund in Sweden, also interventional cardiologist.
I'm Andreas Kaligaropoulos. I'm an interventional cardiologist from Athens, Greece, Mitera General Hospital, Ygea Healthcare Group.
My name is Mike Gundeken from Amsterdam. I'm an interventional cardiologist.
I'm Nilesh Parikh from King's College London.
And finally, Klaus Bonaventura from the so-called Klinik Ernst von Bergmann in Potsdam, Germany.
So I think it's fair to say we've got an incredibly experienced panel who have used NIRS IVUS for many years. David Erlinger's probably I don't want to call him the godfather because it has sort of chronological connotations, but I think it's fair to say David is the godfather. So this is a Nipro-sponsored event, but as I said to you, I think it's really important that you can all understand this technology. So David's going to start off with talking about what NIRS IVUS is, what does it tell us, what does it give us, how does it do it. Then we're going to talk about some data, much of which David has produced and others on the panel have produced, about why we should use it, what evidence does it give us to make a difference to our patients. John and Nilesh are then going to give some cases, some clinical cases from the last 12 months when we've been using it a lot, and how the information that NIRS IVUS gives us, how it changes the practice and how it changes what we do for our patients. Then, of course, vulnerable plaque and inflammation is an extremely important nidus for acute coronary syndrome. So it's about how can we locally and systemically modify plaque vulnerability. And finally, to sort of sum up with the cases, with the discussion, what is the future role of NIRS IVUS in performing PCI to improve the outcomes for durable PCI for our patients? So without further ado, I'm going to introduce David to come up to talk about NIRS IVUS, the journey from sort of academic into clinical practice and the prospect data.
Thank you very much. It's a pleasure to be here and talk about the clinical evidence of NIRS IVUS. And these are my disclosures. So NIRS IVUS catheter is like an IVUS catheter. You get a very high resolution IVUS that is excellent, but you also get what we call NIRS, which is near infrared sound light that measures the wavelength of cholesterol. So cholesterol absorbs a certain wavelength. So by doing this, the catheter can detect where there are lipids, and you can see these chemogram with big yellow blobs where there is lipid, and red when it's fibrous tissue. And this has been trained on pathological specimens, and it has used some sort of AI to learn what is a vulnerable plaque, what is a plaque that causes myocardial infarction and sudden death. And you see the three upper panels are lipid plaques, and the three lower panels are fibrotic plaques, and the fibrotic plaques are red. So we did the Prospect 2 study, 900 patients, where we did IVUSNIRS in all the three vessels, and then we followed them for 3.7 years. And we also had a treatment in this for a pilot study. And this is a typical example. You can see this non-culprit lesion here that 3 years later caused a myocardial infarction. When you go back to the chemogram from the index procedure, you can see that there is a lot of yellow here. It's max LCBI 687, which should be around 68% lipid in this area, this 4 millimeters. You can also see the non-culprit lesion 2, which didn't cause an event, and that was red. So we learned from this study that NIRS, with these chemograms with the lipids, can predict what plaques will cause myocardial infarctions and other revascularizations. And what's very much assuring is that there are two prospective studies, the LRP and Prospect 2, and the results are close to identical. Patient level, odds ratio of 2.5 or something like that, and segment level odds ratio of 4 or 8 in the two studies. And you see the curves, so you can nearly put them on top of each other. So very solid evidence for this, for the NIRS algorithm. But the most interesting thing is what we could do in the Prospect 2, that we could see both plaque burden, which we know is a risk factor for vulnerable plaque, and NIRS. And if you have none of them, nothing happens. You're home free, you can start smoking, you can do whatever you want, because nothing will happen. But if you have one of them, you're up to 1 to 2% event rate on just one segment. And if you have both, you have 7 times higher, 7% risk. So odds ratio is 36. So solid evidence, the combination plaque burden and NIRS is the dangerous thing in a plaque. So how should we now treat them? That's a big question. You could do it locally with mechanically, with some stent of sort, or you could do it systemically with, for example, PCSK9 or maybe anti-inflammatory. And for PCSK9, the Pacman study could show that after 1 year with PCSK9, you could reduce the lipid content by 40% and maximum CBI by 31%. So it really reflects the effect of these lipid-lowering therapies. And we did the pilot study, the Prospect Absorb, and we were not powered for hard clinical endpoints in significance, but we saw a 60% reduction in segment-related MACE. So very promising. And now we have the PREVENT trial that was presented some months ago, who also identified vulnerable plaques, for example, with IVUSNIRS, and they could show that by treating them with either Absorb or a modern drug-eluting stent, they could reduce event rate substantially with a p-value of 0.009. So suddenly, these non-flow limiting plaques that are vulnerable are, we have evidence that we should treat them somehow. And it just finished with a case we had some weeks ago, a woman with some troponins and 50% stenosis here in the LAD. FFR is negative, so physiology says you should not stent this. We looked at it with IVUSNIRS. You can see 71% plaque burden, 395% lipid, 39% lipid, which is totally significant for a vulnerable plaque. So we stented this lesion, and I'm very confident with that. And I think that this is where we are now. At least borderline lesions we can now treat based on these vulnerable plaque characteristics. So in conclusion, the NIRS IVUS identifies a plaque that will cause future MACE. And we can treat them systemically, for example, if there is widespread disease, and we can treat them focally with stents or other products, drug-coated balloons and so on, if there is solitary proximal lesions. Okay, thank you.
Thank you. Thank you, David. I say there will be lots of time for questions throughout this session. Can I just have a show of hands? Does anybody have NIRS IVUS currently in their cath lab, and are they using it routinely? Arms right up, please, so we can see. So a handful of users, 4 users in the audience. That's interesting. Okay, so maybe John, if you can go and give your case. So I think the key things, and John will explore this now, is that the IVUS is outstanding quality. So the IVUS quality is the best in class and is better than others that are out there, the Boston that we have in our lab as well. And then, of course, it's about then the chemogram and how you utilise that extra NIRS information to decide how it changes practice for your patient. So both John and then Nilesh are going to talk through cases, and after each of their cases, 5 minutes for you to ask them any questions about their utilisation and their experience within the cath lab. So thanks, John.
Thanks, Tom, and thanks to everybody for coming, and thank you for the invite. So there's my conflicts of interest. So I'm just going to run through a brief clinical case, and I hope it just stimulates some thought and discussion. So the case is of a 77-year-old male who was kind of incidentally picked up because he had atrial fibrillation, and the history was fairly unremarkable. He had very mild angina and breathlessness on exertion, but nothing that you would get too concerned about and perhaps, treat it medically. Peripheral vascular disease with some claudication and hypercholesterolemia. He was on the usual sort of therapy, medical therapy, to treat what turned out to be very severe LV impairment with an ejection fraction of less than 30%. His hemoglobin and creatinine were normal, and this is what we did. So he came in for an angiogram, and lo and behold, it proved that he had an ischemic cardiomyopathy with triple vessel disease, some angiographic calcification. We actually enrolled him into the BCIS CHIP study. For those who don't know, that's a randomized study looking at supported PCI versus standard PCI with the use of LV assist impeller. So he was randomized to impeller, which obviously you can see there on the left. This was his angiogram, and I show you just the left coronary artery. We did treat the right coronary artery as well, but the left coronary artery proved to be the most interesting. And you can see he's got a fairly long diffuse disease in his LAD. It's pretty tight looking proximally by the diagonal, but further disease downstream. And when I saw this angiogram, I felt, well, I think what I'll do is I will probably modify the plaque proximally, and then I'm going to place a stent proximally. I was very unkeen to get involved in the mid to distal disease because it just didn't look very attractive for stenting. So I decided I was going to rotablate up front, rightly or wrongly. So the wire passing down, that's the rotor drive wire, no problem. And then a 1.75 burr just to treat that proximal segment to prepare me for stenting. Once I'd rotablated, with my standard practice, I decided to do an IVUS run. We like to use the Dual Pro IVUS+NIRS catheter, not least because it gives you absolutely fantastic IVUS imaging, which we'll just demonstrate here. So here are the cross-sectional images. Round the edge here, we've got fibrous plaque turning in yellow there, so it's coming into lipid plaque, and it tells you where the lipid plaque is situated, as well as, I'm sure you agree, giving you very high-quality, high-definition IVUS. And I'll just let that run through so that you can hopefully see the run there. So we've got mixed plaque, it's calcified, but it's also, surprisingly for me, actually very lipidic as well. So I'll just let that finish just so that you can see the whole run. Just coming up to the top end of the artery now. The other thing to say, it's got a very long and quick pullback. So 150 mil pullback, which is incredibly handy actually, because I think normally with other IVUSs, we'd have to do a couple of runs here and then try and patch them together. So I've just given you some stills here. So what we have here is a still of the angiogram on the left here. And then we have the chemogram and the chemogram data given to you on the right here. So we have distal and we have proximal. And obviously, as David has already told us, anything that is yellow is highly lipidic. And it will also give you the lipid core burden index, 331, but perhaps most importantly, based on the data, is the max LCBI over 4 millimeters, which is right bang in the middle of the artery, somewhere around about here. And that's coming in at 733, which is massive. So actually, this is pretty vulnerable plaque going from top to bottom. And so what this has done, at least in my hands on that day, was decide that actually I'm going to treat much more of the artery than I'd planned to do. So here's just some still illustrations. I've picked my landing points. I've decided to go much longer, and I've got decent landing areas in terms of IVUS, but also making sure that I've got full coverage of the lipid plaque. So some more rotablation just to make sure that the calcified lesions down distally are properly treated, and then 2 overlapping drug-eluting stents, one long one that covers the sort of more distal segment and an overlapping one proximally and then post-dilated. Giving a very pleasing angiographic result, both here in the epicranial and then here in the caudal view. So the patient tolerated the procedure well, and the patient went home the next day and made a fantastically good recovery. So what are my take-home messages just from this case? Well, the Dual Pro IVUS probe identifies the size of the vessel at the landing zones and calcium distribution and its need for modification. The Dual Pro catheter gives excellent best-in-class IVUS imaging, the best I have seen. The NIRS identifies the location of high-risk lipid plaque, which does guide your stent placement and coverage to make sure that you're covering the full extent of the vulnerable plaque. And data, if we extrapolate it, should suggest that that is going to make a difference to our patients. And then finally, NIRS IVUS helps to guide stenting even in challenging situations like the case that I've just shown you, such as with diffuse complex coronary disease. Thank you very much.
Thank you, John. A really, really nice demonstration. So not just a straightforward proximal lesion, but a really diffuse, horrible calcified disease. Any questions from the audience, please, to ask John specifically about either this case or the technology or how he uses it in his practice? Any questions from the floor? Yeah, please.
Do you want to come up? Do you mind coming up to the microphone so that everyone can hear? Thank you. Including me, because I'm going deaf in my old age.
We can also identify lipid-rich plaques by OCT, as you know. What are the positive things that we can get by NIRS IVUS?
Okay, that's a really good question. Thank you. Well, I think the first and perhaps most obvious one is the fact that we don't have to use any contrast, and sometimes that's quite important. Not always. This is IVUS, and we don't need to clear the bloodstream like we do with OCT. The second thing I would say is that it gives you a really easy way, I think, of identifying lipid. So the problem that I tend to find with OCT is that I've got to look at all of the images, and you can have, 2,000 frames in an OCT run, and to look carefully through those to identify where we think the vulnerable plaques are, I find, at least, in the heat of the moment in the cath lab, to be quite difficult. I think the great thing about the NIRS chemogram is it immediately trains your eye to where the vulnerable plaques are, and then that allows you then to get on quickly and modify the vessel as you need to do, and then stent. I think the potential other, obviously, advantage of this is because the IVUS is so high quality, it really gives you a great idea of what the plaque burden is as well, even in very large vessels. So when you're using it in ostial rights, left mains, and what have you, OCT sort of tends to fall over at that point, whereas NIRS IVUS, I think gives you excellent information.
Yeah, I have a question. I was wondering, how do you prefer to reload the catheter? By leaving it in the vessel, or pulling back and loading outside? Yeah,
so thank you. So the great thing about this catheter is that the back end of it, where you've got the operator control, sits on the bed with the patient, and it's got all the buttons on that control that can set you where you want to be. So it's obviously a rotational system that's inside a plastic catheter, and the plastic catheter is down the artery, and it pulls back within the plastic catheter. When you want to reset it, it's very simple. Press a button, it resets. So there's no need, like with other catheters, where you have to manually get it running and push it back down the catheter, at which point sometimes the catheter can kink and so on and so forth. This just has a button that will just reset it. The other thing that I really like about it is that it's also, if you've seen something interesting on your run at 30 mils and you want to take another look at it, you can then get it back to 30 mils on the run, have a good look around, sort of go back and forth up and down the catheter using the buttons on the console that is on the bed for you. So it gives you complete control over the system.
Thank you. Just my question, does identifying the high lipid core change your planning for PCI? For example, do you encounter more no reflow in those PCIs?
Yeah, that's a good question. So the case that I've just showed you, and I think Nilesh will probably expand on this a little bit. The truthful answer is I haven't seen any data that proves the point. But in the case that I had, we had a lot of no reflow. At least I didn't take any pictures because I couldn't see the point in taking any pictures of a slow flowing artery. But I could tell by the way that the patient was agitated and the patient had some ST segment elevation that there was some no reflow. So I think that's going to be a really interesting area of research to look at the cases with high lipid burden and see how many of them get no reflow or slow flow. And is there anything that we can do differently? So you could argue maybe I shouldn't have rotablated there. I should have been a bit gentler. Maybe I might have got less slow flow.
It's a really good point. There is some data out there that with higher lipidic burdens that you have higher IMRs when they've measured it post PCI. So I think you expect to have maybe more distal embolization, just like we had with this case. So I mean, what can you do about it? I don't know, but maybe forearmed is forewarned, so you know maybe that you've got a more challenging case with maybe some more distal embolization later. But I was just going to ask the panel, if there's no further questions from the audience, just going to ask the panel. So John's used it to extend his stent a little bit here to cover what he believes to be more vulnerable type plaque. Is anybody else on the panel doing something similar, and do you think this is a direction of travel for us?
I think we are now. We've got data from PREVENT, data from Prospect Absorb, showing that in non-flow limiting lesions that there is prognostic benefit. So I actually look at it the other way around. If I've got a tight lesion, I feel more confident if there's lipid to treat that more aggressively. And I think we also know that landing into normal architecture, trilaminar architecture is useful. So I think if you put all of the data together, flow limiting, vulnerable disease within flow-limiting disease is really your class 1A indication for PCI now, I think. So I certainly do, and I'd be grateful for other comments.
Just to add that it gives us additional further information. It's not a replacement of the IVUS. It gives us additional information, and it changes the strategy during the procedure. And the landing zone would definitely be different, and the long-term result definitely also. Sure.
Yeah. Okay.
I think the interesting thing is here, I might just mention, is that this guy had very mild angina. In fact, he didn't present to me saying I have angina or have chest discomfort. He presented with atrial fibrillation. And so you could criticize me for treating this patient at all. Maybe I should have just given him 2 anti-anginals and told him to sort of go away. But I think, seeing all that lipid in the artery has actually made me at least feel better, that I feel like I am treating something that potentially is going to cause this chap a problem if I don't. Now, I know that's probably a very controversial statement, but there is more and more data out there, as you are seeing, to suggest that we should be targeting vulnerable plaque, not necessarily plaque that's flow limiting.
That's a fair point.
And one more comment.
Please.
Another useful thing is to evaluate after the PCI the result by repeating the NIRS IVUS and see how the actual lipid core burden has been reduced. And sometimes we can see that there is significant reduction, which probably reflects some positive clinical impact for the patient.
That's a very good point. So there's some very nice and elegant data out there that if your LCBI is greater than 250 in your stented segment, your risk of target lesion failure is greatly higher. And so there's not maybe too much you can do about that, maybe with the vessel at the time, because you've post-dilated it, you've made it as big as you can. But certainly, I think one would be extremely aggressive with anti-inflammatories and the statin therapies and maybe inclisiran, PCSK9s to really get on top of those risk factors. So if it's okay, John, we're going to move on to Nilesh. I think all of us, it's fair to say, find that calcium is some of the biggest problems that we face as an interventionalist. Delivering equipment, preparing vessels, whether it's thrombectomy, whether it's IVL. The NIRS IVUS, obviously the IVUS gives us great imagery of the calcium. It always will, because it's the way in which the imaging works. But we also are now getting a better understanding of how NIRS can also add to that. And Nilesh is going to present some case and some thoughts about how the lipidic components of calcified disease may require different therapies and how he can get the best long-term outcome for his patients. Thanks, Nilesh.
Yeah, thanks, Tom. Thanks to EuroPCR for hosting this interesting session. I'm going to show a case now titled "Calcium, Is It Always Hard?" These are my conflicts. The case is an 86-year-old gentleman with stable angina, CCS class 3, a background history of hypertension, and an ex-smoker. He's got spinal canal stenosis and uses a stick to mobilize. He still goes outdoors 3 times a week and has pretty significant angina. He has mildly impaired LV systolic function, so we moved on to invasive chorangiography. This is the RCA, which shows diffuse mild calcific atheromatous disease. However, the left mainstem showed severe critical distal left mainstem disease with extension into the trifurcation, disease advancing into the LED and circumflex. You can see angiographically that there's severe calcification with tramline calcification within all 3 vessels. The cranial view shows that this extends into the proximal LED up to the solitary diagonal. So, in summary, severe multi-vessel coronary artery disease with left mainstem involvement, a high syntax score, but also pretty high surgical risk based on age and mobility. So what we did is we took him off the table and we had a heart team consult, and overall it was felt that he had preclusive surgical risk and was referred back to us for percutaneous options. So I actually did it on the day. I was quite worried about the severity of that distal left main stem. And like John, I went with upfront rotor ablation. Apologies for my technique there. Interestingly, as I finished it, he also developed slow reflow with a brief episode of ST elevation. I then proceeded to perform NIRS IVUS. And the image on the right is moving from distal to proximal where the orange bar is. And as John said, you can see very clearly that the grayscale IVUS is very high definition indeed. I agree that it is best in class. And also, as it comes north, you'll see that there are certain areas of lipidic-rich plaque, but also several different calcific morphologies. So let's drill down into that a little bit more. Well, the proximal LED shows near circumferential calcification, but no lipid really at all. This is sort of conventional circumferential calcification that we all deal with on a daily basis. But a bit like John, I was surprised to see that the distal left mainstem lesion was also a near circumferential calcific plaque, but with pretty high lipid burden, an LCBI of 438. And that's important because, first of all, that might be implicated in the slow reflow, but also, as Professor Erlinger showed, that also suggests that this is a vulnerable plaque with a high risk of future events. And it's important to say that, of course, NIRS IVUS is really the only modality that gives us this level of information. And finally, the distal left mainstem had two protuberant nodules with no lipid, more conventional and classical calcification for this location. And why is that important? Well, I think as we get more information in this field, we might treat these lesions differently. So the proximal LED with the circumferential calcification but no lipid, I think we're pretty happy to just use conventional calcium modification, atherectomy, IVL or cutting balloon. However, for that distal left mainstem lesion with a pretty high lipid core burden index, perhaps less is more. Maybe we could have just done conventional predilatation, avoided slow reflow and periprocedural risk, which we also know is associated with future adverse outcomes. And then instead, we can concentrate our time on the protuberant nodules, which are potentially harder to treat. Perhaps ignorantly, I went on to do IVL and completed the procedure with a 2-stent calotte to the left mainstem. And on the right-hand side, you see the chemograms. And again, there's some interesting information. The top is the pre and afterwards is post. And as Andreas mentioned, you can see there's a significant reduction in the lipid core burden index at the end of the procedure. Secondly, the grayscale IVUS shows really fantastic luminal gain, again, hoping that we improve durability of clinical outcome for the patient. And finally, as Tom mentioned, our lipid core burden index dropped from 438 to 143. So we're really hopeful that we've prevented future events for this gentleman. So in conclusion, I think that NIRS IVUS, the dual pro catheter and the dual modality imaging really can now increase our understanding of calcified plaque morphologies. I would say that this is really the only modality that can do that currently, and this may impact on calcium modification therapies in the future. Thank you.
Thanks, Nilesh. Are there any questions on the case here? Please go to the microphone. Thank you.
So I'm trying to understand, how do you reduce your lipid index merely by stenting? Is that because you send the fat downstream?
Yeah, it'd be good to hear comments from the panel, but I think that there are probably at least two different mechanistic views on that. The first is distal embolization. So as you balloon and stent, you're sending down lipid and debris into the microvasculature. The other is by scaffolding with the stent and ballooning and then scaffolding. You're in a way, you're sort of almost compressing the lipid really and making it finer, and then obviously scaffolding it with the metal. And I think the combination of those two is why you see a reduction in the lipid. But I'll be grateful for comments from the panel.
David, anyone else? Go on, please.
Yeah, I think it's part is destabilization, but part is also mechanical. If you have a plaque and you treat it, the plaque will be completely different after stenting. It will get stretched out all the way. So I think the lipids are also divided in a bigger volume, more separated in the vessel wall. And I think that's why the near infrared doesn't pick it up.
I mean, I think, I agree with that. I think potentially what you're doing here is that you are mechanically, this is what we do in angioplasty, right? We're mechanically changing the plaque and the vessel. And we're taking a risk when we do that, of course, and the patient's taking a risk, but you hope for an uncomplicated procedure. And then, we're hopeful that when you get this outcome and you've changed something with a big lipid core to something that's now been squashed down and pushed out and it's behind a stent, that may in some way sort of instantly stabilize that lesion. And we kind of see it all the time, don't we, with ACS patients who come in and they don't truly settle down until you place the stent or until they have bypass surgery, and then afterwards a lot of them are absolutely fine. So I think this is just a way of seeing that in real time.
I totally agree, but I just want to add that knowing that DCB will help in this setting, knowing that Alirocumab might help in this setting, so there might be definitely multiple ways that work in that setting, not only the mechanical.
And one more thing is that as much as useful is proved to the handling the calcium here, because I think that's very important. I mean, on how to deal with calcific plaques. Perhaps sometimes we don't have to be so aggressive. I mean, based on the findings of the NIRS and the lipid core burden. I mean, the other things that when you have a soft plaque without a high lipid profile, then in that case, perhaps because of fibrotic burden, it might be useful to use like cutting balloons or scoring balloons to appropriately modify the plaque.
Yeah, I guess it's understanding things so much better so that we can tailor our therapies and then personalise it for that vessel, isn't it? My final question to you before we move to the last case, Nilesh. Have you got any feel for if there are different lipid makeups within nodules, and could that be something that could be important longer term? Because nodules are the bane of our life.
Yeah, that's a really good question. I think we need to do more research on this particular area. From OCT and IVUS, we know that the two main nodule morphologies are true protuberant and eruptive calcified nodule, and the eruptive tends to co-locate with acute coronary syndromes. There's usually thrombin or fibrin overlying those plaques. What we don't know actually, and we probably need to do this research together, is the lipid content and the variability between those two. Hypothetically, the protuberant should have less lipid, should just be a rock of calcium. The eruptive, which is associated with ACS, should have more lipid. That's the first comment. And then the second comment is, we'd like to know whether the stables do have more protuberant rather than eruptive. So I think it's a really exciting area at the moment.
And I think I might just very quickly add that I think the modalities that we have traditionally relied on don't tell us what we need to know, because an OCT can't see far field, and so you don't get to see what's underneath a calcified nodule. And of course, standard IVUS, you don't see anything behind the calcium, so you don't know what's hanging around behind there. So I think that this is going to be an important modality. I think for we've got an elderly population who are presenting with acute coronary syndromes, and this is actually more common than we think.
Well, thank you, Nilesh. It's a fantastic case. We're now going to move on to Dr. Grundeken, who's going to kindly talk about the LRP debut study, which is looking at exactly as we just previously talked about, how can we modify this lipidic vulnerability, and can we modify it with drug-coated balloons? And his centre has run the debut LRP study, and he's going to tell us about that and give a sort of inside future view of what's coming down the track with regards to local therapies for vulnerable plaque. So thanks very much, Mike.
Thank you for this introduction. On behalf of my co-worker, Bimmer Klaas, who led this pilot study, I would like to share some of the results. I have no conflicts. Very briefly, because it's already mentioned before by Professor Erlinger, but we all know lipid-rich plaques are present in up to 50% of all ACS patients and are associated with an increased risk of clinical events. And with IVUSNIRS, we are it's very easy to identify them, as is shown before by the other panelists. You make one pullback and you have a chemogram and all the yellow, so you know directly where the vulnerable plaques are. And there are some studies already with prophylactic preventive PCI, both with bioresorbable scaffolds in the prospect absorb, but also in the more recent prevent study, also with drug-eluting stents. It was shown to be safe It reduced lipid burden and also improved outcome, but still it's a scaffold, and also you have the scaffold associated, stent associated with complications. In 2020, there was a very interesting paper in JACC Translational Science with the rabbit model, in which they treated the progressive atherosclerotic rabbit model with paclitaxel balloon, and they showed that the inflammation really got stabilized, and the progression of the atherosclerosis was completely stabilized compared with vessels which were not treated. So that led to the idea to have some pilot study, the debut LRP, in which we wanted to test this hypothesis in a small group of patients. We aimed for 20 patients, and what we did is in the non-ACS patients, we treat first the culprit, and then we did the IVUSNIRS of all the other vessels to identify if there were lipid-rich plaques, which we considered to be if the maximum LCBI 4 millimeter was above 325 based on Prospect 2 data. And if the patient had one of such lesion, it was treated with a paclitaxel-coated balloon only, not other balloons or high-pressure balloons, just the paclitaxel-coated balloon, 1-to-1 ratio to the vessel artery, and also for the 60 to 90 minutes, and only at 6 atmospheres, so no high pressure, only to deliver the drug. So these are the primary results. The red dots are the baseline values per patient, which were of the treated segments. And then we see that there was a reduction at 9 months with an absolute change in maximum LCBI of 131, and relatively that's 42%. And you see that almost all lesions went down, except for a couple, but numerically only 3 didn't went down, the others went down also numerically. So, and what's very important to note is that the post-treatment maximum LCBI was unchanged. So it was 400 before, and afterwards was also 400, and only at follow-up it was reduced. So it was not this was not mechanical. There was no the lipid was still there after the balloon. We believe it's really the drug delivery, the drug like in the rabbit model, what was proven there that is interfering with the plaque and the atherosclerosis and the plaque progression. We also had in the same page we decided to only do one lesion with the DCB, but most of the patients had multiple lipid-rich plaques, and so we have a control within the patient. And if it's not treated, you see here there is no change. There is numerically some change, of course, but that we know from the statins and maybe the PCSK9 inhibitors that is also influencing the plaque, but this is less and not statistically significant when compared with the DCB-treated lesions. So I found a case example, typical case example. So this was a patient was treated here in the marginal branch, and then we did a pullback in all vessels, and here proximally there was a lipid-rich plaque. You can here see the IVUS. I agree, by the way, with the quality of the IVUS is very, very good. And you see here that there's like a low echogenicity, suggestive for lipid, and also you see here the chemogram was the maximum LCBI was 466. So exactly at that location, we did a paclitaxel-coated balloon, and then patient got back at 9 months. Here I want to show you the post chemogram, post balloon. There was not really difference, a little bit lower, but not so much, 466 to 394. But that follow-up, it was all gone. It was all gone. And it was not the only patient in which we saw this. So it's very interesting. So what were our lessons learned? That this was the first in-man study who does the preventive PCI in high-risk plaques with a drug-coated balloon. And it showed a reduction in maximum LCBI and without any major safety concerns. That's of course very important if you do preventive therapies, not to have complications. So the next step will be a larger randomized study with surrogate endpoints in also reduction of maximum LCBI, but then with a control group randomly. The name is Delete LRP. We're now finalizing our protocol and funding But if you're interested, please feel free to contact us. Again, Bimmer Klaassen will leading this study. And I want to end with thanking all the staff and co-workers who helped with inclusion and with the trial. Thanks.
So, fantastic presentation, incredibly interesting. We definitely want to be part of it, by the way. Any questions from the audience, please? Yes, please.
Yeah, Ron Waxman, wonderful presentation, great concept. As the PI of the LRP, the original, I'm pleased to see that there is a follow-up to that. My only question, how do you know that the reduction in the lipid core was not a result of statin therapy or best medical therapy? Because obviously you're going to have control group in the other study, but we have seen other studies like the Pacman that can happen. Yeah, so how much are you attributing this to the paclitaxel versus other patients were from that on best medical therapy?
Well, definitely there's also some part is the medication, so it's not only the balloon. And we don't know exactly. One hint is that in the non-treated vessels of the patients, there was no reduction, not that much. So we have a control group within the patient, control lesions. But of course, that's why we want to randomize. And first, not a big randomization based on clinical endpoints, but first to prove that it is also, if you randomize and you don't do anything in the patient, because there are so many confounding factors within the patient with medication. So I agree with you. This is not, I'm not advocating now to do DCB in all lesions. No. Still more research necessary. Yeah.
Any other questions from the audience? Just while people are having a think, I was slightly taken aback by the lack of acute reduction with the ballooning, because certainly when we do a pre-dilatation, another IVUS run, and then obviously an IVUS run at the end of our stenting, we often see quite a big drop in the core burden index in between a pre-dilatation and before we put our stent in. Does that suggest you think you're just literally sizing it perfectly because you've got the IVUS and you're not causing any damage to the vessel?
Very low atmosphere.
Yeah.
Just that it with DCB you only need to have that is touching the wall. That's enough. You don't need high pressure. So I think that's it. Only 6 atmosphere, and if you do pre-dilatation, I think you go a little bit higher. So I think that's the difference.
Yeah.
Thomas?
Please.
First, we also want to participate in the study. And second, I only want to underline how important is this step, because in my opinion, it opens for a new window for the future. And it is the first time that we have that other already called preventive interventional cardiology. It's the first time that we approach a lesion without any significance, without any clinical significance, reducing future events. And we will see what tools might be appropriate in the future, but those results are really promising. Congratulations.
Andreas.
So congratulations, really fantastic study, and definitely opens a new concept for drug-eluting balloon angioplasty. What I would like to ask is, the sizing of the balloon was based on media diameter on the IVUS?
Yeah, it was luminal, because you want only have the luminal connection.
Okay. Do you think that if you predilate with like another balloon, I don't know, maybe a scoring balloon, that would facilitate the drug delivery into the tissue? Do you think that this would have an impact?
Yeah, but further? I think that's too risky. I think the drug delivery will be better, because there are studies very very sophisticated with which they really measure the dissection planes and areas, etc. And with DCB trials, and they saw the longer term result were better if you have large dissection planes. So it's a little bit counterintuitive, but I think for these kinds of preventive PCIs, I wouldn't do that. No, but definitely drug delivery is better if you have dissections. Yeah.
So we have one
Maybe
more comment.
Short
please.
comment. Because we don't know that paclitaxel is anti-inflammatory, and we do know that sirolimus is, maybe you would consider to do it with a sirolimus eluting balloon rather than the paclitaxel eluting balloon. It would be interesting to see, because on sirolimus we do have some data. this is available. The other thing, you can infuse colchicine into those lesions. You can do other things that are measured known as anti-inflammatory, because they are the one that brings the lipid-rich plaque. So this is just a suggestion, but...
Yeah, but thank you. But the study in the rabbits was with paclitaxel. That's why we specifically choose that the paclitaxel balloon. So we believe there is also anti-inflammatory response with paclitaxel, but yeah, in the future need to find out. Yeah.
So last comment from David, and then I'm going to wrap up if that's okay.
So I think this is a fantastic study, and it opens up the field. As you say, you could deliver other drugs and you can do other things. I think it's so interesting that you had an effect on the lipid core or the inflamed lipid core, but no effect on plaque burden, which is, would you leave the plaque burden there? And it's the same thing that we have seen with statins and with PCSK9. They nearly do not affect the plaque burden, but they have a great effect on the lipid. And as I showed you before, to have a really vulnerable plaque, you need both the lipid and the plaque burden. So it will be very, very interesting when you get your clinical data, if that's enough to take away the lipid, or if you need to take down the plaque also.
Okay, well, thank you. I'm just going to give our take-home messages from the session that we've put together. So I hope you've all seen with the use of 3 cases that it clearly is the best-in-class IVUS. It's easy to set up. It does a beautiful, long, quick pullback, and the setup is quick and easy with lovely software and handling in your lab. I think we've also shown that NIRS can identify high-risk plaque features, and we can understand the vessel morphology so much better to individualize the treatment of each of our patients. We've seen already that it can support strategy and lesion preparation and maybe where we land our stents so that we cover all of those highly lipidic and high-risk areas. There's clearly some extremely early but thought-provoking data upon the use of maybe DCB for local treatments, maybe other things locally, but also, of course, then pharmacology systemically, and I'm sure we need to work harder with those drugs too. And finally, I think calcium is the bane of most of our lives. And I think that if we can understand calcium nodule and other morphology that will be able to be treated in a personalized way, then I have no doubt that will result in better outcomes too. I'd like to thank all of the panel members for a huge amount of time and effort and put into an extremely engaging and interesting session. I'd like to thank all of you for attending, and I'd like to thank Nipro for supporting this session. Thank you.